Great. How are you this morning?
I'm not too bad, thank you.
Good. What we're going to do is I'm going to ask you to go into audio only just to begin with, so that we get the best bandwidth for, and then later on, if you're taking questions and things, we'll put you back on video. So we're going to have a look at the strategies concerning coronavirus, because this is obviously a very pressing subject for us. And I think what I would like to do is to try to key into some of the fundamental principles so that we are able to respond in an appropriate way. When we're dealing with a systems phenomenon like this, it's very clear that most of the correcting mechanisms are intrinsically there in a healthy individual. And the question has to be what is going wrong for some people in respect of the disease progression, and what the response of medicine is to that, or what the response is from homeopathy to that. I'm going to share the screen and take you through a little bit of background. For those of you who were on the part 9, the intermediate part 9, this will be relatively familiar to you, or parts of it will be, but I hope there'll be some new information in here. The first thing to do is to key in to the natural disease progression in viral illness, because if we can do that, then we can understand where there are variants happening or when things are going wrong. Now, the level and degree of a viremia in an acute viral illness is actually quite important with regard to the symptomatology. And a mild viremia will generally produce only a mild illness, whereas a serious and long-standing viremia will tend to produce more symptomatology and also more complications in the disease evolution. So what we want in a healthy individual, or in all individuals who contract a viral illness, is we want a short and low viremic state, and we want an early primary immune response from our host organism, which means that they should be able early on to prime their T lymphocytes and develop an immune response. And there are certain things that happen critically early on in a disease process. The first is that the patient, in becoming symptomatic, becomes tired, and in becoming tired they should stop stressing and working at the normal pitch. This is because our adrenocorticotrophic response produces tiny spikes of steroid in response to the virus, and these tiny spikes of steroid are important for cell-to-cell signaling. And if we can't see them, if our bodies systemically cannot see tiny spikes of steroid in our bloodstream, then we are less able to produce the kind of cellular immune response that we need. And we can see this in very stressed individuals, people who have a sudden fear of death or who are extremely stressed, as either contextually in their life or because of the illness itself, in that they will have an impaired immune response. And I do wonder a little bit about the doctor in China, the young healthy doctor who died early on in the epidemic from coronavirus, at an age group where he should have been able to shake it off. The real problem at that point was the amount of political suppression that he underwent, and the amount of stress that he had unnecessarily, because he was effectively a whistleblower within a difficult political environment. So one could argue that a sudden high level of stress at a critical moment in the disease process can alter the rest of the disease process and impair the emerging primary immune response. The other thing, of course, that we need to be able to do early in an illness like this is we need to be able to evoke a fever on demand, because our immune system contextually works differently when we are able to evoke a fever. And later on, we need to be able to bring to our membranes factors which will bind viral proteins on surfaces before they actually penetrate epithelial cells. So we need to be able to produce a catarrh later on. We certainly need to be able to produce a fever at some point, and we need to be able to evoke a cellular immune response as early as possible. Our humoral immunity will click in as well when we effectively seroconvert, when our T lymphocytes, when there's a critical mass of them that are primed to respond to the virus. So the emerging humoral immunity has got to some extent to do with the availability of healthy T lymphocyte population. This is one of the reasons why in the elderly population there may be a greater danger, because they may have a slower cellular response. If they've got some immunosenescence due to gut dysbiosis and they don't have a healthy gut flora, then their available T lymphocytes are actually all mopped up, effectively trying to maintain the surface immunity of the gut. And for this reason, it's probably a good idea for at least the elderly population to be on regular probiotics at the present time. There is reasonable research evidence to show that those people who are using probiotics have a better seroconversion rate to flu vaccines, and I think that probably in terms of a humoral immune response to a virus, it probably also holds true. So I would recommend that our elderly population are using regular probiotics and looking after the rest of their microbiome as far as possible in advance of contracting a virus like COVID-19. So you'll recognize that if there is a good and rapid primary immune response, you will overall get a lower viremia, a lower symptomatic phase, and a shorter illness. And effectively, in a short illness with a low viremia is less likely to grow arms and legs and develop into a more complicated picture. If you have a delay in the primary immune response for whatever reason, a combination of stress, a certain number of drugs, suppression of fevers, possible presence of non-steroidal anti-inflammatories which affect the primary immune response by affecting the inflammatory response. If you have a suppression or a difficulty with that primary immune slope, then you will have a much bigger viremia, a longer illness, and people who are predominantly more prone to complications, bacterial superinfection, and or inflammatory failure in organs, including lung tissue. Those of you who are on part 9 will remember this graphic, which relates to the respiratory tree and relates to the viral load in certain tissues. And the different respiratory viruses produce or seem to produce a different viral load in different tissues, insofar as this has actually been studied, and that this affects the symptom picture. So simple rhinoviruses inflame mainly the pharynx and nasopharynx and don't produce a lot of viral proliferation further down the respiratory tree, whereas parainfluenza and influenza viruses have a much broader viral load that includes the nasopharynx and extends right down to the small airways. And probably this is one of the reasons why people are iller with those conditions, with those viral conditions, because they have a bigger viral load, they have more tissues that are involved, they have a higher viremia, and the viral replication and the inflammatory response to that in terms of the release of inflammatory factors and cytokines is probably much higher in these patient groups. Certain other organisms, and this is not viral of course, but Bordetella pertussis has specific inflammatory responses in the larynx and the sublaryngeal tissues, and syncytial virus, as you know, produces a viral load in the nasopharynx and right down in the small airways. The reason why this is important homeopathically is because that affects the symptom picture that we see. So the symptomatology of a rhinovirus because of its locality and its viral load, is a different symptomatology from RSV virus. And one of the challenges for us as homeopaths is to be able to match the symptom picture of COVID-19 to an appropriate homeopathic remedy. And I'm going to go on to have a look at, firstly, what the difficulties are in that process, and also some of the ways around that. Just to remind you that there are certain well-known homeopathic acute remedies that are known symptomatologically to have affinities for these different tissues in an inflamed state. Also to remind you that there are several stages in a viral illness. There is the prodromal phase, which is the contact phase and the early viral replication inside a few epithelial cells. Then there is an acute phase where the viremia starts to produce a lot of symptoms. It produces, firstly, an irritating inflammatory response on the mucosa, but it then also goes on, as the viremia develops, to produce a fever. And then as you move on from that, you get viral shedding, where the endothelial cells burst open and the viruses are actually then shed externally. There's also, of course, viral proliferation internally, and that viral shedding is when the patient becomes infective to others. There is secreting viable viruses in the droplet nuclei that they sneeze out or cough out into the air around them. You then move on beyond that to a phase of resolution where there is a mounting immune response at several different levels, both in terms of the viremic immune response, which is largely dealt with by humoral immunity, and surface immune responses, which has got to do with the release of appropriate antibodies and factors onto surface membranes. And as the immune response develops, there is also a developing symptomatology, but you get to a critical point where the immune response is able to capture or mount a direct response very quickly to new replication within the system. And then you go into a phase of recovery, unless the problem becomes complicated. And we'll talk about those cases which evolve into a complicated state to move either subacutely or chronically into a disease state. Now, unfortunately, with COVID-19, we can get a really nasty illness in a small subset of people, and that subset of people can have an overwhelming illness. So maybe it's not appropriate to use the word subacute in them, because they are not in a really truly recovery state. They are in a state of complication, and we want to have a look at the symptomatology of that, and also have a look at how we would respond in those situations. Now, in the early stage, we have a relatively poorly differentiated symptom picture. We have a dry cough, and we have a rather poorly formed fever, and in different people they will produce a more robust fever than others. It's possible that the patients who produce a really good robust fever will actually have a good primary immune response, but the symptom information that is coming from the caseload and from the available data seems to indicate that this viral infection produces a variable level of fever. It certainly doesn't appear to produce the extremely high spiking fevers that you would get in small children with with RSV. It's producing a much lower grade fever, and it is the case that a few patients will be barely febrile, but will actually have really quite a lot of other emerging symptoms. Now, before viral shedding happens, you have a dry cough, but you can see that in homeopathic terms there's a great number of remedies associated with dry cough. And we have a difficulty early on in the disease process in actually identifying a suitable homeopathic response or similimum to that. And just last night, one of my Italian colleagues was telling me about a couple of cases that he'd treated where the cough was quite painful. It was a hard, dry, painful cough, and he decided on Bryonia alba, which again is a well-known remedy with respiratory affinities associated with dryness and pain. A little later on we'll have a discussion about Bryonia and its potential within COVID-19. Let's at this moment say that in the tradition of treating respiratory infections, Bryonia is more associated with lobar pneumonias and with pleuritic pain than it is associated with acute first stage viral illness. But we'll come to that, and it may be that it is a viable remedy. So what we're seeing, or one of the difficulties we're having at the very early stages, is that the symptomatology is poorly differentiated, and there is nothing that the homeopath can do to increase the differentiation there unless they start to individualize. And you may find, for example, that there are rigors or that there are shivers going up and down the back that help you somehow symptomatically to do a remedy match for that individual patient. It is best if you select a material with a known tradition of use in respiratory infection, but if there's something very idiomatic and unusual coming out of the case, then find the remedy, repertorize them. In my view, it probably doesn't make that huge a difference what you used early on in the illness. Now this is quite a radical thing to say, because most of my colleagues are talking about finding the genus epidemicus for the case. Now, the genus epidemicus is, as I mentioned earlier, is this rather old idea that there is a simillimum for any given viral illness. It came into focus during Hahnemann's time when he was living in Königslutter, and at that time, I think it was the 7 Years' War, or one of the Napoleonic Wars was raging in Central Europe, and what was coming off the battlefield at that time was scarlet fever. And it was a danger to the local communities, and Hahnemann treated everybody with belladonna, and a lot of people responded beautifully to belladonna and eradicated the streptococcus and resolved the scarlet fever. And this is the early use of what one would call a genus epidemicus, the use of a material with a very selective and very specific symptom picture to treat everybody who's presenting at that time during an epidemic. But there's a difference between a viral epidemic and a bacterial epidemic, in that the diffuse symptom picture of the viral epidemics are much less specific and rather less dramatic in the early phases than an acute bacterial infection. So if you think about a cholera or a dysentery, there are very, very marked and a very fulsome symptom picture and a lot of prescribing information very early on in the disease process. Whereas a lot of the viral illnesses, including COVID-19, are producing a subtle, quite insidious early symptom picture. And for that reason alone, it is very difficult to ground a simillimum to the case, an easy simillimum to the case. These are a couple of very, very rough graphs that I've put together this morning, looking at, if you like, the viremia, which is this raggedy black line here, in the prodromal phase, in the proliferative phase, in the viral shedding phase, and in the resolution phase of a common respiratory illness. And the red line relates to the fabric of immune responses, which have got to do with cytokine release and with an antibody or response to the virus. If you get in a young person an uncomplicated viral illness, there's not a lot of symptomatology early on. There's emerging dry cough and fever emerging around here, then there's a catarrhal state, and then there is a gradual resolution state. And this is what we want to see. This is the natural systems disease process. This is the immune response that has evolved over hundreds of thousands of years in human beings It is unclouded, there are no blocks to cure, there are no underlying complicating factors, no vulnerabilities in the case. We have a young, reactive, responsive person who hasn't suppressed the initial fevers with paracetamol and hasn't suppressed their inflammatory response with ibuprofen. So that ideally is the response pattern that we're looking for in a viral acute like COVID-19. The difficulty is in people who are immunosuppressed or where there is a problem with the mounting of the original primary immune response, either the suppression of fevers or the interference with drugs, is that you get a delay in the mounting of the actual immune response, and what you end up with is an unfocused but very high level of cytokines and immune reaction. A lot of inflammatory factors in the system producing a variety of complications in other organs. Because of the delay in mounting the immune response, the viremia then persists, and the viruses then replicate not only in the respiratory tract but in the interstitium and produce a kind of toxemic state within the organism as a whole. So in those cases you get a lot of complicating factors, and you're liable to get organ failure, and you simply also get an exhausted state, a state where there is a severe exhaustion and a very poor and protracted recovery state. So what we want to do is to avoid this as far as possible. We want, wherever possible, to evoke a natural and efficient immune response and avoid a complicated, delayed, suppressed or unfocused primary immune response. If we look at the symptomatology, and what I've done is I have illustrated the symptom picture here with little stars. In a healthy immune response, there isn't actually a very evolved symptom picture. So there is almost no symptomatology early on. As the viremia develops, there is a simple fever and a dry cough, and as the thing evolves, you get a catarrhal state, but the catarrh in a healthy individual may be very limited in COVID-19 and may be restricted to the upper respiratory tract, with very little extension of the viral load into the lower respiratory tract, and with no reactive symptoms, so no secondary bronchospasm, and certainly no cardiorespiratory complication. And then of course you move back to a very simple symptomatology and resolution in the case. However, in a complicated case, the symptomatology can be very variable. You have a low symptomatology very similar in the prodromal phase to the healthy individual, but you then get a more sudden onset and more severe onset of symptoms. And if the patient is unwell for other reasons, for example, if they've got a fatigue state or a fibromyalgia, or they have a problem with asthma, anyway, you will have then a complicated symptom picture. And the number of symptom features I've denoted by the number of spikes on this star. And of course, as time goes on, the slower and the more delayed the resolution, the more the symptom picture evolves, and the more it becomes characterized to the particular vulnerabilities in the individual. So the individual's predisposing weak spots start to evoke stress responses, and eventually the symptom picture can be really quite multi-system, multi-organ, and cause a whole variety of idiomatic symptoms. Now, in homeopathic terms, the simple response here, the simple remedy response here is quite phasic. There's nothing much to do in here, except perhaps to take a few doses of echinacea. In the primary state here, one of the dry cough remedies, maybe like bryonia or manganum metallicum, is maybe relevant in here. During the proliferative stage, things become a little bit more complex, and I will talk a little bit about the remedies that may be indicated in this phase to try and facilitate and shorten the illness. And of course, once the illness is in resolution, you shouldn't be doing anything. Once the case is finding its own way, it's not a case then of trying to force it into resolution. You cannot make a system integrate itself faster than it will naturally. And this is quite an important fundamental aspect of illnesses like this. It is a systems phenomenon, and you cannot manipulate a system back into resolution. You can create the context in which a system spontaneously integrates itself and self-corrects, but there is no way of pushing or forcing or manipulating a disturbed system back into functionality. And for this reason, homeopathy is a much safer response to COVID-19 than most conventional medicines, because there is a fundamental and ideological issue here, in that in conventional medicine the primary belief system, the prevailing belief system, is that you should intervene to resolve symptoms, and that you should intervene somehow to encourage the system into a symptomatically free state. Whereas in the homeopathic thinking, the symptomatology is a reflector of the disease process and not the cause of the disease process, and symptomatic management can actually be very counterproductive and very damaging, because what it does is it produces a complicating layer. With the introduction of drugs or interventions, there's a complicating factor that goes in to the natural immune response and can slow it down. And one might argue, and if this will come out in the epidemiology of this condition ultimately, one might argue that those patients who've had the greatest interventions at critical points in the disease process are at far greater danger. Of course, there are a few cases that progress because of underlying vulnerabilities to a really decompensated state and require an intensive care unit, and those intensive care unit patients may pull through simply because they've got some system support and they've got ventilation, and they're supported for long enough for the primary immune response to actually ultimately kick in and resolve the viremia. But a lot of those patients who reach that stage will die, and more of them will die if they have unfocused or poor interventions at that point. There is some limited information in the homeopathic research concerning the use of homeopathy within ITU departments and showing better outcomes for those patients who were treated homeopathically, even in that late phase of an illness. But that data set may or may not be relevant to COVID-19. We just have to keep that in our peripheral vision, and at the moment it hasn't got a lot of confirmation applied to it. So you will also recognize that there may well be a simillimum here, a single simillimum there, a single simillimum here, and a single simillimum there. And this contrasts more with Bönninghausen's approach to viral illness than it does to the slightly ideological genus epidemicus approach. Bönninghausen in the 1840s, 1850s recognized that viral illnesses have different stages to them and that you may need to change the simillimum. So, for example, in a viral croup, Bönninghausen's his first remedy was aconitum. He would then move on to hepar sulph during the slightly painful inflammatory state, and he would then move on to spongia if there was an extension into the lower respiratory tract with a secretory phase. So Bönninghausen's croup powders are a very good example of the clinical following through of the different phases in a viral illness. Now obviously here we're not dealing with a respiratory syncytial virus, we're dealing with something slightly different. So the clinical picture of that Bönninghausen came to for an RSV in children may not be the response that we need to use in COVID-19. Now, the next thing to consider is the body of information that comes from people like Borland. And again, you will remember from part 9 that we talked about Borland and about his way of staging the different respiratory infections and looking at those homeopathic remedies that have the greatest affinity to the different stages in a pneumonia case. There are predominantly plant remedies, and as you're aware, the plant remedies are a bit more physiologically complex than many of the mineral remedies, which means that their reactivity in a homeopathic sense is probably of a higher order, and they're also better characterized from the physiological standpoint than many of the mineral remedies. But there are, for different plant remedies, different speeds of onset, and there are different affinities for the symptomatology that's going on at the time. So some of them are predominantly fever remedies, some of them are predominantly first intention remedies, some of them have got inflammatory change on surface mucous membranes, and some of them are more associated with the secretory phase. So if we look at belladonna, for example, it's a first stage remedy with a lot of dryness and a lot of heat, whereas ipecac is definitely secretory phase and has definitely got to do with viral shedding, moisture in the mouth, and has got to do with secretions in nasopharynx and in small airways. And the time aggravation may or may not be relevant, but we do have in our adrenocorticotrophic response a primary modifier, a primary physiological modifier of our global illness state as our adrenocorticotrophic function increases in the daytime and diminishes at night. And those are different environments clinically in which the immune response and in which our physiology operates. So you may find that the timing of certain aggravations is important. If you think back to the old pneumococcal pneumonias, pretty often there would be the crisis point would come at night, and people repeatedly throughout literature and throughout the history of clinical medicine in the 19th century would describe the congestive state of bryonia with their lobar consolidation, their very dry cough, going through the crisis of the fever overnight, and then the consolidation then breaking up, then going into a secretory phase and the fever dropping. Now, there are a lot of case notes in the Royal London Hospital for Integrative Medicine that go back to Borland's time that show the timing and the resolution phase after remedies like bryonia or veratrum viridae given in these pneumonia cases. And these do indicate that the correct remedy in second, third, fourth stage disease has a disease modifying effect and will help to improve resolution. What I want to do now is to discuss the coronavirus template. I have taken this through a number of different stages, and I will take it through further as clinical information comes through. So what fundamentally we want to achieve, if possible, is a good primary immune response, and that means making or helping people to be immunologically intact at the outset. What we want are patients who've got poor lifestyles and poor diets and who've got gut dysbiosis or background problems with their microbiome, we want them to be using daily probiotics. In the ideal state, they will be homeopathically treated and given bowel nosodes and so on, but generically at the moment, daily probiotics. We want to try and avoid spread. There is limited potential value in vitamin C and zinc supplementation, and of course if you've got vitamin D deficient patients, they're also vulnerable, more vulnerable. You want stress avoidance, and one of the difficulties in coronavirus is that we've got a media hype which creates a huge social fear, and that fear in itself can be potentially dangerous, which means that reassurance, avoidance of stress, and the very act of giving patients standby homeopathic prescribing, interestingly, may be more important, regardless of whether it's a similimum, than anything else. There are two actions or two consequences that come out of making a homeopathic remedy available to your patient early on. Firstly, in taking something homeopathically, they're less liable to move towards symptom management through over-the-counter medications. They're less liable to be swallowing paracetamols and aspirins or ibuprofen or other things, quite simply because they've been given a homeopathic treatment. And that is in itself important. It is, regardless of whether it's a good similimum or not, it is something that firstly avoids symptom suppression, and secondly it is something where the patients are feeling more empowered in terms of their own fate or their own treatment. And the fact that a patient is able to do something rather than just sitting there twiddling their thumbs and waiting for the sword of Damocles to fall on them, the fact that they're able to do that will reduce a stress response. And in avoiding stress, you're automatically improving the chances that they will have an uncomplicated primary immune response. If you encounter, or if your patient encounters a contact, then you can use echinacea for a few days at the point of contact. Echinacea is a mild immunostimulant. It may have immunostimulatory effects on the humoral immunity. However, like all plant drugs, it shouldn't be used for long, and it shouldn't be used where the patient becomes symptomatic. Echinacea has a primary response, but it also has a secondary response which is not helpful. And so I would recommend that echinacea is used for no more than 4 consecutive days. Anybody who's using it for 10 days, 14 days, 21 days and thinking that it will protect them in those kind of time frames is delusional. Echinacea is a short-term response at the point or shortly after contact. Thereafter, it's important as symptoms emerge that there's the avoidance of symptom suppression, the avoidance of incidental paracetamol use. Now, ideally, you've advised the patient who's using paracetamol, acetaminophen or Nurofen, is using these for incidental problems like knee pain or headaches or whatever else. They should already have stopped them. It's far better for a patient to be suffering an increase in their pain or an increase in the incidence of their headaches than it is for them to end up with an interfered or a subverted primary immune response because the drugs happen to be in their bloodstream by chance at the very onset of the illness. So you want them at this point to avoid symptomatics, to stop work, to rest, obviously to isolate. The COVID-19 nosode, if it becomes available, is not the similimum to the primary illness, and it's not. You can use it prodromally, but you can't use it once symptoms come on. It's not appropriate to use the nosode in the early symptomatic phase. Use it as a preventative in this phase, a single dose of 200C to everybody you know and everybody who you're in touch with at that stage, but don't use it as a primary treatment early in the illness process. So we don't know whether arsenicum album or manganum will be preventative or shorten illness at this stage. They are both associated with dry cough. Manganum is an interesting remedy which has a good affinity for humoral immunity. So if you look at the symptomatology, it is an appropriate response at the onset of the illness, but it may or may not be a useful similimum. I've heard overnight from a colleague in Italy, Dr. Bruno Gagliazzi, that he's treating some of his early cases with Bryonia alba and apparently getting good responses there. It may or may not be the case that it matters too much at the very onset of symptoms. As I mentioned before, the case that is not clouded or blocked or subverted in any way, where a remedy like manganum, arsenicum album or bryonia is introduced where the patient is reassured, you're already doing a significant amount to reduce system stress and risk in that case. In the proliferative phase, again, the patient is becoming more symptomatic, and you may at this stage have a quite significant viral load. You may start to be getting fevers. Typically at this stage there will not be very high fevers. And the question at this point in time is whether or not there is a confused response. And at this point in time, a paradoxical remedy like camphora, used hourly, is probably one of the better ideas, because the camphora helps the patient to move or to mirror its internal responses through very different internal microphases. Camphora is quite a paradoxical remedy. It is quite a diffuse remedy with a diffuse symptomatology all the way down the respiratory tree, and I think that at this stage where the patient has an irritating cough, a non-congestive state with no congestive picture in the lungs, and a non-productive cough, this is a useful prescription. But the difficulty is that you have case reports coming through in patients who are probably quite likely to have responded spontaneously and well on their own with no intervention at all. In Sankran's cases, they were asymptomatic after a couple of days. It is a potential encouraging fact, but at the moment we don't have enough clinical confirmation. As I mentioned earlier, as the disease progresses, the symptomatology becomes more evolved, more developed, and becomes more characterized. You may find in the very fatigued patients who have difficulty in evoking a robust fever, and where there's a very kind of wobbly-legged fatigue with chills, that the gelsemium picture is important. Again, the gelsemium picture is more likely in those cases which are not yet really producing a lot of secretion. So gelsemium 200 C hourly is a good response at that stage, where the patient is very fatigued, clearly viremic, has fevers which may or may not be poorly developed, and there's some chills, and there may be a degree of restlessness in the case as well. As time goes on and they move into the viral shedding state, the question is whether or not the secretory phase is purely a natural secretory phase in the upper airways, or whether it's extending down to a significant viral load in the lower airways. What tends to happen here is that there's a lot of vagal stimulation, and the cough reflex becomes more accentuated. The dry, irritating cough becomes a moist cough, and at this stage the vagal irritation is more likely to take the patient towards vomiting and nausea and vomiting. These patients have a moist mouth rather than the dry mouth of bryonia or arsenicum, and they are catarrhal. If that secretory phase moves towards a congestive phase, and they're getting lung congestion, and they're starting to get a difficulty with the lower respiratory tract, some wheeze, and some bubbly bronchial secretions, then you need to move the remedy forward into something like spongia. This may be particularly important in those patients who are elderly or who have got a poor cough reflex, or who have had the cough suppressed with codeine, and who have therefore retained some secretions. And again, those patients where there is cardiopulmonary problems or cardiopulmonary vulnerability, cor pulmonale or long-standing cardiac asthmas, these patients are starting to move into, or be more liable to move into the congestive phase, and their secretions are more and more difficult to expectorate, because they're involving the small airways, and the surface tension of the secretions makes it more difficult for them to actually expectorate those. The question then has to be whether or not you're dealing with a much more complicated case where the problem is really becoming more serious and much more worrying for the patient. And this is, in the younger patient, this is nearly always because they have suppressed part of their immune response with symptomatics, and this is where these remedies come in. Where you've had antipyretics and anti-inflammatories used early in the illness, where there's a high cytokine release, and where you're getting muscle responses and reactions, rigors, muscle pain, lassitude, and there's also likely in these cases to be gastrointestinal upset as well. In those cases where you can use China officinalis, where there's myalgia and aching and fatigue and incomplete fevers. China sulph, where the spit is becoming mucopurulent and where there's redness and fever with perspiration. And China arsenicosum, where there's periodicity and an entanglement between the symptoms and the 24-hour clock as their cortisone levels rise and fall, with very marked pallor, restlessness and fearfulness in China arsenicosum. If they then move on to a really pneumonia picture, and it's the very small airways and the actual lung tissue which starts to show signs of inflammation, then the lung tissue is becoming stiffer and they are having a great deal of difficulty. They're using accessory muscles, there's respiratory distress, there is, with the cough, increasing pain in the intercostal muscles and a heaviness and a constriction in the lower chest. The patient may be holding on to their rib cage in order to give themselves or to allow themselves to cough, with costal pain and wheezing respiration. And the great temptation is to try and make these patients comfortable by using analgesia or by using paracetamols, and it is just not on. You mustn't, even at this phase, use symptomatics. You will kill your patient if you start to use poorly focused symptomatics in these cases. Unfortunately, they have to suffer to have the best chance of recovery. So if they become congested to this level where their oxygen saturation is dropping and they're getting air hunger, you have to think about Carbo-Veg. You may use it as a few stat doses. Obviously these patients will be hospitalized, they'll be maybe on oxygen. It may be that if we have a very bad epidemic and we don't have oxygen and hospitalization options, then we're dealing with in the domestic environment the use of Carbo-Veg at this point, to try and improve oxygenation. So the other thing that can happen, of course, is that in a very long trailing state, that you can get bacterial superinfection. It seems to me from the available clinical evidence that it is likely that the patients themselves are not, most of them who are getting severely ill, are not extending to this phase. Most of them are dying with a viremic state and with severe lung congestion, pneumonitis, and a very impaired oxygen saturation. And there's not a lot of evidence that the patients who are actually dying are actually moving forward into bacterial superinfection. Most of them are dying primarily as a result of a serious COVID-19 viremic state with secondary organ failure as a result of dropping O2 levels. I think that if you have a patients who have gone through the primary and who have been debilitated after the COVID-19 and then developed bacterial superinfection in the lungs, then these remedies may be relevant. I would, as a general rule, be thinking of moving back into Borland's protocols, and personally I would be using Borland's pictures to decide on the best remedy for those patients. But as basic stock responses, then these remedies may be relevant in patients who have effectively recovered from COVID-19 but in the debilitated state have then moved into a secondary pneumonia. I think then you would maybe think about those. And finally, those patients with severe states where you have got pneumonitis, where they are in very severe hypoxic states with poor oxygen uptake, where there's a viremic condition which is causing cellular decompensation throughout the body, then hydrocyanic acid 30C every 30 to 60 minutes is probably the best similimum to that particular state. It's a very whether or not you can pull these patients through is another matter. They will probably, those of them who are lucky enough to be in intensive care will be receiving intensive care and probably won't have access to that. But if you have patients in that state, then I think that that's a reasonable prescription, a last-ditch chance to turn things around. Generally speaking, when you're getting a clinical response and people are moving into an appropriate phase of response or reaction, wait, pull back on the frequency of your prescription or stop altogether, see what happens, and don't try and push things any faster than they'll go. There are a few suggestions at the bottom of the crib sheet that relate to the post-infective sequelae, and they may or may not be useful. They're not the most important part of the protocol. So that is a very rapid and quite intense overview of the current thinking as far as I can see it on coronavirus. It is important that patients learn to understand that there is nothing in paracetamols, acetaminophen, and aspirin that has any healing property at all. The only thing these can do is interfere with the primary immune response, and it's the single most important message to get out. It may be more important even than identifying the similimum to the early disease state. What I'm going to do is you can now open your microphones if you want, and you can ask me questions, and I'll be very happy to try and answer as far as I can your questions. I'll just take the screen sharing off, and I hope that we'll be able to take things up. So is there anything that you'd like to ask that emerges out of that? I'm sorry it was a bit of a romp through, but I'm hoping it's reasonably lucid.
What about prophylactic aspirin?
What about
those that the patients are on it for stroke prevention?
Yeah, at 75 milligrams and the use every day may or may not be that important if it's a kind of 70 milligram enteric-coated aspirin. I'm not sure. I think that probably if they became symptomatic, on the balance of risk, there's a much lower risk in stopping the aspirin for 2 or 3 days at the very early onset. So I think that if it was my my mother or my father, who was on a prophylactic aspirin, if I thought that they were in the early stages of a coronavirus infection, I think I would ask them to stop it for a couple of days on balance of risk. It's the timing of these things. It's the fact is that your primary immune response and that primary immune slope may only be critical for a few hours. It may only be 8, 12 hours, and once it's really established, and you're evoking the appropriate primary immune response, the rest of the disease process is radically altered. So I think I would ask them to stop it. If at the very onset of symptoms. What's much more controversial and much more difficult is the question around steroids. Now, if patients are taking nasal sprays and they're treating a really non-complicated problem with steroids, there's no question that they should stop steroid nasal sprays around this time. Whether they've got hay fever or chronic rhinitis, you should not be using nasal sprays at this critical time. People who are on oral steroids, I think there is no question, you just have to leave their steroid regime going. Apart from that, some of them who are on significant doses of steroids could have a steroid or adrenal crisis if you stop them suddenly. So I think we've got to be a bit careful with that one. I don't know, does that answer the question? Is that helpful?
Yeah, that's good. Yep.
Anybody else got?
Can I ask about the dosing? You say it's Bryonia hourly. Do you mean hourly for 24 hours, or hourly for 3 doses, or hourly for?
Well, I think that to some extent, you have to feel your way through things. During acutes, generally speaking, you use high potencies and you use them frequently. And you also look for change. And I think that in a coronavirus, to use for the first day or two in the early phase, 30 Cs, hourly, 2 hourly, even 3 hourly, you'll be able to detect a change probably within 12 hours in that early prodromal phase. When they're in a more dramatic phase, you're wanting earlier signs than that. Now, if you look at Borland's pneumonias, he tended to use very high potencies. I mean, he was using 1Ms, 10Ms, CMs. I don't think that is necessary. I would say that you can use 30s, 200s, 1Ms, and in those, as the illness is evolving and it's becoming more critical, it's quite legitimate to use those hourly. You can't produce proving symptoms or complications, but what you're wanting to see is evidence of change, 6, 8, certainly within 12 hours. You're wanting to see evidence of change, and if you're not seeing change, then you need to change your remedy, you need to rethink it. So in the early illness, everything's a bit fuzzy anyway, and if things go absolutely beautifully, the patient will end up with what looks like a simple cold, and they'll just pull out of the whole thing, and within a couple of days they'll be fine and there's no problem. As things become more critical, insist on the remedies, use them more frequency at high potencies, but there is a caveat in that if the patients move into a really debilitated state, so for example, if their physical energies are very low, and if they're elderly, and if their resources are a low ebb, then you need to move back towards more modest potencies, 30s, 12 Cs even, and use them frequently in these debilitated states, because once you get to into a very big illness state, their ability to respond to really high potencies is not so high, but you need to keep the frequency of the dose up. The main thing to remember is you cannot cause harm with the homeopathic remedies. You cannot cause in an acute something which is going to cause a proving state. You can only cause systems clarity if you've got the right remedy. You need to be prepared to change your prescription as the disease progresses and evolves, and don't get stuck with just one material if things aren't working out.
Okay, thank you.